And we're live in 5, 3,
2,
1.
Well, good morning, everybody. My name's Jens Chapman, and welcome to this new year. Today is January 3rd, 2024, and welcome to our STED Talk, Spine Technology Education. And I always reemphasize the D stands for discussion, debate, discovery, and that's a great lead-in for today's lecturer. We're greatly honored to have Dr. Nwosu here. I'm going to introduce him in greater detail later, but he is a graduate of UCLA, did his fellowship at MGH in Brigham, and he's here with us in person. He practices in the South Sound area with Neo Spine, and he is one of those bright young people who does phenomenal work with great new technologies. And speaking as the old dinosaur that I am, I'm always keen on learning it, and I will participate in the D part and the debate part. And Ken, thank you for coming up here also. It's great to have you in the front row here next to me. He's right here, so here's Ken, and he'll debate with us what's going on. And we have our fellows that have selected a couple of cool cases. Some of them just came out of the OR late at night with me, so we've not seen one another for about 4 hours or so, but they all look good. I think Dr. Brian Anderson is going to be first with a case that we took care of, and we'll ask Dr. Nwosu for his opinions.
Yeah, thank you very much. Good morning, sir. All right, so I have one case that I'm going to present. It's a 58-year-old female. She's a store clerk. She has a 5-day history of progressive neck pain with some difficulty swallowing. She's got right upper extremity weakness, some numbness in her arm, and then she has pain that's going down both of her arms. She has fevers, some chills that have been going on for a few days, and then imbalance and some gait ataxia. No trauma, no prior symptoms. Her bowel and bladder is fine. When we examine her, she's got this forward bent neck. She has a decreased sensation in that arm. She has 1 out of 5 motor strength to the C5 distribution of the deltoid and the bicep on the right side, and the remainder of the right upper extremities pretty weak at 4 out of 5. Notably, her inflammatory markers are all elevated, her CRP being 355, and her BMI is on the obese side. Medical history is significant for diabetes that's not controlled very well, hypertension, and periodontitis. You can see her motor exam on the side here. So here is the imaging that we have available to us. You can see on the left, it's a mid-sagittal cut of a CT scan showing focal kyphosis at 4-5, C4, C5, and advanced spondylotic changes at C5 to C7. And then we have 2 more mid-sagittal slices to the right. So we have a T2 in the middle, and then a T1 post-contrast here, and I have them looped. Unfortunately, there was some significant motion artifact during this MRI, so these are just about the best sequences that I could pull through here, demonstrating significant edema in that retropharyngeal space, and a little bit of increased signal and uptake in the C5 to C7 vertebra, and increased fluid in the ventral aspect of the epidural space. So in summary, I have this patient with acute cervical myelopathy. Based on her history and exam, she's got these elevated inflammatory markers. We have this presumed retropharyngeal abscess from C1 to T3, and then we have a questionable osteodiscitis from C5 to C7, and she has severe spondylosis with kyphosis. So at this point, we come to our decision tree of how we want to progress with treatment. We can always stay conservative with IV antibiotics. We can move to surgery with an anterior irrigation debridement. We can add in some kind of decompression and stabilization procedure to that from the anterior aspect as well, or we could go big and go front, back.
So if you go back, that's a very nice summary presentation, Brian. Can you go back to that summary picture? Yeah, that's probably a good one. So Ken, I don't know how it is in the South Sound. You're practicing about 35 miles south of us, but you're in a very busy practice. This has become an everyday occurrence for us. In my residency and early practice years in the 90s, this was like one of those rare cases. And this is literally a daily occurrence for us now. Not daily, but certainly weekly, twice a week, sometimes 3 times. Surgery, no surgery, what's your thought?
Sure, certainly. So great presentation. I do hear you that this is becoming something that we see more often. I cover call in the South Sound for about a week at a time, every 6 weeks. So this is something that we see on a regular basis. As it relates to your specific question, in my opinion, this is certainly a surgical, a case that needs to be managed surgically. Patient clinically presented with dysphagia. So I think that sort of forces your hand to go anteriorly to address the fluid collection that's sort of building up in the front. There's the option to consider a multi-level ACDF or the option of a corpectomy. I'll be interested in seeing a little bit more information as it relates to sort of her to see if she corrects when she extends, but that may not be very pertinent towards making the decision to execute an adequate surgery.
And with retropharyngeal abscess, is that something that, let's say you get the call at 6 p.m. on a Friday evening, are you going to take that patient to the OR Friday night? Are you going to wait until Saturday morning? Or I could accelerate the question by saying right in front of a clinic day on a Monday night prior to Tuesday clinic?
Sure. Well, this patient isn't straightforward. Obviously, a patient has diabetes, probably multiple other comorbidities, and there isn't really, at least based on what you've presented so far, an acute progression in motor function. Or did I miss that there was?
She was quite normal about a week ago, and this
Okay.
has all transpired over a process of 5 days.
Yeah,
Okay.
so she has complete or near complete shoulder abduction and biceps weakness and
Sure.
searing arm pain.
Sure.
She
Yeah.
literally sits like this.
Yeah. So I would try to get to this within 24 to 48 hours.
Okay. So one of the things you're going to talk about, cool new toys and tools, and you'll see where this heads to, and that's decision making and risk management. So this is just full disclosure, but without being too, I'm staying very opaque here, too concrete. Rod, middle of the night OR for you?
Probably, is there a CT scan?
This is CT.
Yeah.
You showed it earlier.
Yeah, I just have a mid-sagittal
I mean,
cover here.
We see this a lot, unfortunately. Usually, they need kind of a workup, like blood cultures.
Yeah, blood
echoes, ID.
Yes, sir. So blood cultures were obtained during this time. They did come back positive for MSSA. She did have an echo, and I think this one was clear. And then she has a CRP at 355, ESR at 120 something.
I mean,
count
I
of
was
14.
on call over New Year's, and we had like 6 or 7 of these, and we operated on one, but again, the whole, usually these patients come in with sepsis, they're cardiovascular compromise.
Yeah.
They need to be stabilized. I would not recommend doing this middle of the night. They need to have, like the person we operate on, needed blood pressure support and came in with high white count, CRP, SED rate. So I think you got to medically sort of stabilize them, and then they do need surgery.
So let's fast forward here in the interest of time to keep momentum going. So she, if you go back to that MRI, Rod, she has pretty bad disease at 5, 6, 6, 7. I'll put you on the spot here. Her weakness is profound C5 with searing, a classic like textbook C5 policy. Would you include C4, 5 also, although that doesn't look so
No,
bad?
I would just do, I think if you just go after, I think the 2 levels is fine. I mean, she'll get better.
Ken, what do you think? Go to C4, 5 also, because that's the clear, no question neurology.
Sure. Given the circumstance and situation with which she's presenting with this acute progressive, loss of strength in her deltoids, I would only address the problematic areas at this time, especially if I did it in a sort of urgent basis within 24 to 48 hours. And if problems start to occur in the future at other levels, then sort of live to fight another day.
All right, Brian, take us forward.
Sir, so
Drum roll.
we did proceed with surgery. We did an anterior carotid approach, and then we did an IND the both abscesses, retropharyngeal, and then this what was very obviously an epidural abscess, which we accessed by doing a C4-5, 5-6, and 6-7 ACDF, and then she got an anterior plate. The surgery is uncomplicated. EBO is 100, and she got a drain.
And I used allograft, just to, so my next question is, should we use some high-tech graft for which surgeons for some reason get paid more, like titanium or PEEK or off-label bone morphogenic protein, or is allograft an infection the best choice?
Well, in my opinion, would be to try to use some metal rather than allograft, given the fact that it can sort of propagate a potential infection. So my choice would be to use metal titanium.
Rod?
I personally like allograft,
Yeah.
just because it seems to have a good biologic, component, and usually the bone's kind of soft.
And we used there are 3 articles, and one of them actually came, I'm proud of that, from Harvard with Jim Schuster now at UPenn, and we actually followed allograft, and we did not have a comparison group that was scientifically sound, but we did compare it to others at the time. This is again a mid-90s or early 2000s study, and allograft had the best results, actually. So it's a biologic thing, but it's not available in all countries. And again, here in the US, for some reason, our CPT makers have decided we don't get paid as much. But we did bicortical screws. And any thoughts on that, bicortical screws?
So, certainly, I agree with bicortical screws. I mean, as biomechanically sound you could be in the patient like this, the more sort of bigger the screw, the more bicortical it is, the better, in my opinion. So I agree with that.
Are you totally at odds with what I did there? I think we did a 3-level ACDF. Is that too radical? You said 1 level?
No. I don't think it's radical. I would have done just the C5, C6, and C6, C7, just in the vein of, hey, these are the symptoms that the patient's having at this point in time, and these are the issues that need to be addressed urgently. I've had situations where I've, in some instances, tried to prophylactically, not necessarily prophylactically, but try to treat other levels that may not be causing symptoms. And then there's risk associated with that, and I've gotten in trouble. So I tend to be pretty conservative and address the symptomatic levels, especially in an acute setting like this.
Rod, so I went all out 3 levels. Do we go posteriorly now also?
I think it's fine. I think you can follow her and see how she does.
Brian, what do we do?
Well, this is what we did for today, or that day at least. In summary, at this point, we already know what her diagnosis was. We know what she got. She had this MSSA bacteremia, like we discussed, Dr. Escuian. She was on Ansef and rifampin. Unfortunately, on post-update 3, she had some AFib with LVR, so she was on heparin drip and then eventually bridged over to warfarin. And then acutely on post-update 15, she had a large swollen right anterior lateral neck. She had some serosanguinous drainage from her drain site the drain was pulled from, but she was really asymptomatic otherwise, no stridor, dysphagia, and she had normal phonation. In fact, when we saw her in her room, she was eating her dinner. She was quite happy. So at this point, we had to make a decision as to what to do next in a largely asymptomatic patient, but with a large clinically fluid collection. On this mid-sagittal axle, you can see some tracheal deviation to the left side, and then you can see a large fluid collection on the right side.
It's 15 days out.
Yeah.
So life in anticoagulationville. When do you start patients on anticoagulants if you're forced to, both arms are turned to your back? What are you going to allow them to do?
So obviously, as you know, try to avoid by all means necessary. But if I have to, typically 48 to 72 hours.
So no contest post-op day 3 AFib. It's okay to proceed.
It's okay to proceed with
Anticoagulation.
Yes.
So 3 weeks later, she gets a breakthrough bleed, probably double dosed. We don't know. But we took her to the OR rapidly and washed that out. But now the plot thickens, so she's never really
Was there
recovering.
blood clot there?
Yeah,
Jens?
big,
Wow.
big, semi-organized. Did you help me with that?
Yeah, I did. Yeah.
How would you characterize the hematoma?
Large. And
Yeah.
it was hematoma. It was a bunch of jello. Yeah.
Yeah.
What was her symptoms? Did she have respiratory distress?
No.
Just say-
We got
say?
called at night. I raced up because the nurses said there's sudden swelling in her neck. It's a
Wow.
very nice patient. We all really liked her. And she has this balloon in her neck out of nowhere. And I thought we'd race her to the OR because we've had airway problems before. And she was sitting there, and the nurses had actually called us about it, to their credit. She was sitting there, I think you were with me also, and she was sitting there and eating dinner. Like, okay. Hello, Mrs. So-and-so, can you say something? Yeah, this is good dinner. It's just like, have you noticed this balloon in your neck? Good food. Okay, yeah, so, okay, yeah, well, maybe we'll wait until the morning. Well, maybe we'll just hold your anticoagulants in the morning. And
Wow.
so we did a washout, I think, in the morning.
We did. Yeah. And she did well.
So we washed that out, and then she comes back, and now the plot thickens.
Yeah, so she did really well after that second surgery, the washout, and then unfortunately, right around 5 months, she comes back into the office. She has this X-ray. You can see there's some rotation of the plate, and collapse of the vertebral bodies, and she has a persistent right C5 palsy that's been present since prior to her initial surgery. But again, she's asymptomatic. She feels pretty good, and she's already returned to work as a store clerk. So at this point, we have to decide again what to do in this otherwise asymptomatic patient. I have a CT here that we can go through real quick, mid-sagittal, coronal, and then axial. You can see the hardware hasn't failed, but she does have fractures in many of her vertebral bodies. I think I said 4, 5, and 6, and she has essentially instability in her neck now, as she has multiple vertebral bodies that are not really hooked up to each other anymore. They're trying to collapse on each other.
So Ken, so there's, and the reason why we're showing this is you're going to talk about enabling technologies. It's going to be very focused on how to put screws in correctly and where to decompress the spine. I'm going to go into decision making. So had we had a risk assessment computer, what would the guidance have been? Would the guidance have been do less surge in the front, or should we back it up from posterior right away? There's somebody named Jeff Wong from an institution that you're probably familiar with. At the time, at least, he was there. And there's a landmark paper of ACDFs and non-unions and 3 levels. Do you remember the number? I'm going to put you on the spot.
Like 85%.
It was high.
Yeah.
So was I foolish to hope? Yeah, it was 50% for 3 levels, I think. So was this foolish? Was this predictable?
That's a complex question. I think at the time, this was not foolish. I think a 3-level sort of ACDF and sort of seeing how it goes. I think even though the pseudoarthrosis rate is relatively high, there is a chance that this patient fuses. But if the patient doesn't fuse, again, you live to fight another day. You can sort of address the potential complications that come up. So I don't think it was foolish. However, I do think artificial intelligence and sort of risk stratification instruments can help with sort of better decision making for patients like this, where there are sort of comorbidities that we may not be considering when we're considering taking this patient to the operating room urgently.
Rod, I'm looking for affirmation from you or condemnation. Should I have just done a posterior surgery on her right off the bat? I mean, she's actually doing well, except that she has a profound motor deficit still in her biceps, but she's happy. She's back doing her job.
I mean, I think probably intraoperatively, was it pretty soft?
Yeah.
Was it
No, the bone was okay.
Yeah, it was good.
I mean, I was actually pleased.
I mean, this is a difficult case. I don't think he did anything wrong. I mean, how many weeks?
It's about 5 months.
5 months.
Yeah, clinic follow-up.
How about, what was the scan? Was there plain x-rays and stuff
plain
like that?
X-rays,
Yeah, everything
they
looked
looked
good.
fine. And then at 5 months, the whole thing just blew apart.
It's tough. I mean, I think you did everything right.
So now how do we solve it, Ken? Got a mess in the front and
Yeah, so I would say clinically, if she's making progress and her dysphagia is improved, the implants sort of look to be within bone and not sort of moved significantly. So I would just leave the front alone and go posteriorly.
so the front is actually blown apart. The bottom and the top have literally windshield wipered. But
Yeah.
we'll move forward. Yeah, sorry, go ahead.
Yep. So
But we listened to you.
we did do that. You can see on post-op day 153, we did a C2 to T2 fusion in the back and a laminectomy, a wide laminectomy from 3 to 6, and then a focus for aminotomies due to her persistent C5 palsy on the right. And then a few days later, we took her back to the operating room and we did removal of hardware, the plate and screws, did corpectomies of 5, 6, and 7. And then we did a 4 to T1 fusion with fibular strut allograft.
We did a translaminar screw at the top there, just in case you wondered, because she had an aberrant vertebral artery with cavitation of the C2 lateral mass. So we did a translaminar screw. Do you have a lateral of that?
Unfortunately, that was the only plain film I had, but I do have this last CT here, mid-sagittal, coronal, and axial.
So we tried to correct her coronal plane deformity as good as possible. We went posteriorly first, just like what you said. Then we did a multi-level anterior allograft. So we tried to push her head over, but it's what we got. And we did a translaminar screw on one side. So the learning points for us here, for me, are, I mean, again, spine is always amazing to me and so unforgiving. And again, I'm still not sure. I was very pleased how the front surgery went. We had very good purchase, but it obviously did not heal. The bone, to answer Rod's point, was actually pretty good. You were with me at the index procedure, right, also? Or was that not you?
That was before I got here.
So I thought we had good purchase there. This is obviously a very difficult situation. That multi-level corpectomy was not easy. Dr. Patel helped me with that, right? That was not a straightforward surgery, actually. And we tried to improve her alignment. She's actually very happy. She actually felt that her shoulder and elbow, interestingly, felt better, although on the preoperative CTs, we did not have a clear pathology. Any chances for this allograft to heal?
Certainly, especially with the robust posterior construct that you have, I'm hopeful.
Let's hope so too. Brian?
Chance to heal?
Do you know what actually heals in on these long strut grafts?
End to end?
This end-to-end 10% max. Yeah. So the center remains avital and at best remodels over time. Interestingly, the best healing chances are when that allograft has some contact to the left or right residuals of the vertebral bodies.
Yeah.
That actually can do spot welding, which is considered desirable.
Okay. Yeah.
So we actually wedged that in. So what are you going to do when you're on call starting August 1st in your September 1st in your new place? Are you going to take this patient to the OR in the middle of the night? Are you going to use titanium? Maybe titanium would have healed better.
I think that I might be a titanium guy. I'm not really sure what I'm going to do
Get paid
in that
more.
regard.
Get paid more.
Yeah. And I think this is difficult, and this just shows when you do despite doing a good surgery, unfortunate complications can happen. So I don't know that if we went one way or the other, that we wouldn't have ended up with this last slide. I'm not sure.
All right.
Can I ask a couple of questions? A couple of questions about this case. Number one is sort of what are your thoughts on in patients like this with just poor biology, what are your thoughts on using autograft, harvesting autograft for a multi-level ACDF like this? That's number one. And number two, how much do you think the patient cleared her infection? And do you think she had some residual infection going on and maybe that contributed to her sort of late failure? And were you guys able to assess that before going back?
Yeah, so she was, with her ID colleagues, she was treated appropriately with 6 weeks of IV antibiotics, and she did clear it based upon inflammatory markers. And then when we did our repeat surgeries, there wasn't any evidence of active infection, although she did have the neck anteriorly that we went into several times was obviously a little scarred in. So
So in terms of autographed, great question. I must say in Next don't do it anymore. Like I think most people, but that's not a good excuse. But she had a pretty sizable paniculus. So I would have not been thrilled about going there. But that's gold standard, no question. AI would have told me get the autographed, but I still get it very rarely, and known high-risk patients might have to go. But again, in her case, that would have been heavily weighted by having a high risk of symptoms from her front. All right, we spent half an hour with this, but great presentation, great discussion.
Yeah.
And who's going next? You want to do yours next? Yeah. Is that okay with you, Cliff? Yeah, okay. All right, Neil. Neil has an easy case.
Yep.
Thank you, Brian. And Neil Patel is with us from Penn State, and neurosurgical colleague, great guy. He knows all the tech tricks. He knows how to adjust the height of the lectern. And I must congratulate him. He takes some drug that's amazing, because he was in the OR with me until the wee morning hours. So, and here he is, vibrant, the picture of youth. All right, Neil.
Ready to talk about Ford versus Ferrari. So we had a gentleman come in. He used to kind of race cars and had a terrible accident with that, and presented to an outside hospital. We did not see him in this initial kind of evaluation at the outside hospital. It's a 71-year-old rollover motor vehicle accident. It's a vintage racing car, so of course doesn't have all the tech of the new cars with the inflatable seat belts and this and that. Did get purge facet C7 there, and we don't have pre-op X-ray or CT scan, so I do have a compression fracture of T5 here. Just excuse the hardware. That wasn't that he didn't present with that. It's just that we don't have pre-op CT scan of his thoracic spine, and this is his CT scan of his neck pre-op.
So this is a man who, again, a great person, out of state crash. He lives out of state in the vintage car racing circuit. Crashes his car, has a neck fracture dislocation and an upper thoracic fracture. Is neurologically miraculously normal. And a local surgeon then decided to fix one fracture, which is an old Harborview paradigm of ours. Fix at least one fracture if you have two fractures, and then treat the rest. Again, it's easy for us to second guess, but the surgeon tried to somehow do something in the upper thoracic spine, and I think I'll just fast forward that here. It looks kyphotic, and the neck is still dislocated.
Yep. So he's very affluent. So he went to 5 neurosurgeons and then underwent this C2 to T7 posterior instrumented fusion, closed reduction of 6-7, but it wasn't reduced. I'll show you the CT scan. He did have T5 burst fracture again, which wasn't kind of addressed and was left in this kyphotic deformity. So this is when he kind of presented to us 1 year after that surgery with posterior neck pain, muscle tightness, mid back pain, and bilateral hand tremor. He could not, use his cars the way he wanted. He wasn't racing anymore, but he couldn't even go to his shop and do the things that he wanted to. You could see that the jumped facets or purge facets are still kind of in that position, so that wasn't reduced. And T7 or T5 compression fracture with the kyphotic deformity again is fused in this deformed position. So he's in a significant sniffing kind of position.
So he has a substantial deformity now. So he has a very significant upper thoracic kyphosis, and he walks basically with a forward projected head. I forgot what the nickname for that position is. We heard it and learned it. This is bone density. This is unfortunately spinal bone density, but substantial deformity. He has some cervical stenosis. I mean, this was, until this crash, an extremely active, vivacious, life-embracing person. And yeah, go ahead, Neil. Sorry, I interrupted you.
No. So that's perfect. Bone density was normal. MRI I showed, and this is the most important because this CT myelogram showing the cord and any areas that we'd worry about, but looked like he had really good open.
So he pulled out his screws at the bottom. They kind of windshield wiper it downwards. and he remains dislocated in his neck, and his cervical hardware is actually pulled out also. So he has non-unions, staying with the non-union theme.
Right there, up there. And now again, just getting worse. These are his uprights, both sides. Have significance. So we did take him. Should I?
Oh, wait, yeah, no, go back. So what should we do? I mean, there's a dislocated neck with a non-union, an attempt to go to C2. Those screws assume, I think you have them on the sagittal CT, are all pulled out. Basically, it's a non-union, malunion of the subaxial spine, and whatever that, is that T3 or T4? Neil, do you remember?
This is T7. T5, T5 is this one, the compressed one, yeah.
So what to do?
Yeah, so this is certainly a very complicated case, a great presentation. This patient needs to be clearly revised. However, this needs to be done electively. Given, that he doesn't have any progressive neurologic deficits, I would sort of walk it slowly. First of all, consider optimizing his bone density if possible, and second of all, consider some sort of traction treatment prior to surgery. Ultimately, I think he'll probably need a VCR corpectomy either at C7 or T1 posteriorly, and extension of the fusion to C2, hopefully not up to C1, and then also further down. You can also consider pedicle screws in the cervical spine rather than lateral mass to get a more biomechanically robust construct.
Rod, any thoughts? So 2 deformities, malunions, non-unions, loose hardware. Do you correct? How do you get into that cervical deformity? How do you correct the thoracic deformity?
I think probably you're gonna have to go from the front for the cervical part, and then the upper thoracic junction is kind of difficult.
How are you going to get to C6 with that? Show them the manubrium. How are you going to get to that C6 area?
Yeah.
It's literally vertical.
Yeah, I mean, I think it'll be, I think I would go in, take the hardware out, and then see what he looks like, and then potentially stage it and go anterior, and then probably have to do VCR of that compression fracture.
All right, Neil, take us ahead.
All right, so we decide to go from the posterior first. So here, first 2 shots are putting these upper cervical C2 screws. We did go down to L1, and then this is IDO around T5 to kind of get that sorted. So we had that. Then we did drill out the facets at the jumped facet region, and then we stapled him close. The stage 1, we flipped him, went anterior. You can see us again kind of pin that the jumped facet area. We did get good decompression up and down, and then placed a spacer and kind of fused that, and then went back posterior. And now you could see the compression around our IDO. So this distance kind of reduces over time. And we did overall get a great correction. And these are his post-op. So he now has C2 pedicle screws. He's down, fused down to L1. He has an IDO, and he has an anterior correction of that jump facets and opening that area. And once that's done, these are his pre-op versus post-op shots. So he's standing up better, significantly better than he was before. He is corrected in both kind of sagittal and coronal planes. And 2 years later, he called us during Christmas, said, he feels very pleased with the results of the surgery, and everything's working out for him. He did have some post-op short time, needed a PEG, but that kind of reversed, and he's doing really, really well and able to do everything he wants to do in life right now.
So thank you for that presentation. This is a difficult case to unravel. So learning points for me, again, this is going into decision making, but also goes into surgical navigation. We did not have surgical navigation. We just were careful as much as possible. And we did, I think, get 1 or 2 intraoperative CT scans just to make sure everything was in safe places. But this was like a long case, 8, 10 hours, something like that. We did what you kind of said, back, front, back. And we did try to go for the best possible correction in both places. I think what Rod said also, but we completely disarticulated C6-7 from the back. We literally stripped it to nerve roots at 2 levels and skeletonized the vertebral artery, and then used traction intraoperatively in a supine position. We still had to use a anterior osteotomy thing. We could have not accessed the front. This was still, the hardest part of the surgery actually was that anterior part to get down into that anterior neck because it completely scarred down. It's like a revision surgery to get down there. We did warn him about swallowing difficulties. He had swallowing difficulties going into this, so we did give him a PEG tube afterwards for 3 months, and he got that out. But the main points is this something that could have been avoided? So for instance, when we have robotics and surgical navigation nowadays, optimal screw placement for me is not just putting it into the proper spot, but having a decision-making help in terms of osteodensity and purchase. Is that present yet in this current generation of navigation aids?
So that's a great question. I certainly see the value of information like that within technology. It is not currently present in the current generation technology that we have. But to what you alluded to, I mean, you're able to not just accurately place the screws where you want to, you can also sort of place them in the most biomechanical way possible. But obviously you've been able to accomplish this without such technology, and not too many people can do that. So kudos to you and your team.
It's our team, and again, it's just persistence. I think less talent, more persistence. Rod, navigation. You're again old school like me, but you also you have an open mind towards new technologies. Subaxial fixation. Would you have, had you had navigation, used subaxial pedicle screws? We did obviously long pedicle screws at C2, but we did, I think, use pedicle screws in other levels also. So would you have done pedicle screws also with computer navigation, or?
I mean, I think it's getting there. The only thing is we use Gardner-Wells tongs for ours, so it's not a Mayfield clamp. Unless you absolutely have to and there's no other way of getting fixation, I mean, I think the risks of putting a pedicle screw are pretty high in the cervical spine of having a vert injury or something. So I think I mean, this is a great correction. I don't think you lost anything, especially we went in from the front by not putting in cervical pedicle screws in the subaxial spine.
So Dr. Nikat Ahmad, thank you for joining us, and salam to Pakistan. Traction prevalently, Dr. Nwosu talked about that. Would traction have helped? Neil, you've spent some time looking at this case. I know you weren't there at the actual case.
Yeah.
Conceivably, do you think traction beforehand would have helped?
He was fused, so no. If he had done it before his previous surgery, when he was fused in that kyphotic position, definitely, I think. But after he's fused, not really, because the only thing that would have moved was C1 and C2, because he was fused from C3 down, and it was loose. And so I don't think so. Unless once we opened him up, I think it helped here. So it helped after stage 1 when the rods were out, and we went to stage 2, and we were doing this anterior part. This is where it helped, because now everything is kind of mobile, and you're trying to get that couple millimeters, bring his head, kind of the angle off of the sternum.
That was my thought as well. It's always good to think about traction beforehand. We in our hospital can't do that anymore. Our hospital took away our striker beds. So our nice $18,000 plus beds here do not have cervical traction setups anymore. I could look at Dr. Escuyan as the chief of our spine service why he allowed that to happen, but we don't have, at Harborview we had traction setups with these striker frames where you could do cervical traction. Do you actually have those?
No,
absolutely
not.
So you don't?
We do not, no.
The rod changed my life. I was one of those Mayfield head tong persons, and I've totally, almost completely switched to intraoperative GW tongs. And this was a case in point. I mean, you could literally start feeling that there was a little give when we disarticulated the subaxial spine. It wasn't loose yet, but it was going places. Yeah. And so having an intraoperative dynamic traction, Dr. Nikad, Ahmad, would be is very helpful for me. And this was a big game changer, having quality Gardner Wells tongs and having a variety of weights set up and being smart about where you put the pins relative to your external auditory meatus. The preoperative traction in him would have honestly probably not done anything. I'm not saying that this is wrong. In this case, it would have not made a difference. This was a battle of endurance. It was an endurance race, a 24, almost a 24-hour race, a 12-hour race. But yeah, Rod, any other thoughts? I mean, so first of all, thank you for changing my life with GW tongs.
I think part of the reason, again, I don't really, I learned this when I was in New Zealand, is that they don't use Mayfield clamps there at all. In fact, when they do craniotomies, they just use a horseshoe headrest, and you're able to turn the head. So I think Mayfield clamps in the US, I think are, especially in neurosurgery, I think they're kind of like the standard. But when I was in New Zealand, they didn't use it. And so I sort of started thinking about the spine, and cervical thoracic deformities are perfect because it's the ideal setting. The patient's paralyzed, muscle relaxed on, they're sedated, you have neuromonitoring, you can see if there's any changes, and then you can literally on the table, you can put 50, 60 pounds of traction without any problems. Yeah. So I think, I prefer doing intraoperative versus, on the floor. So
Combined with a surgical release.
Yeah.
Learning points for you, Neil?
Yeah, I really the kyphotic deformity correction and getting the angles was kind of the biggest learning point for me. And tackling a challenging case like this, kind of thinking of 3 stages, breaking it down into the kind of your goals and achieving that, I think has now kind of changed my opinion on, okay, well, I don't really need to just do posterior or anterior. There's a way to kind of address it back, forth, back. Yeah, it takes flipping and this and that, but it's totally worth it when you look at the last result. So thank you. Yeah.
Thank you. Good job. Garrett Lewitt is here. He's our research fellow. He just came back from his home in Germany where he spent New Year's. Thank you for jetting back just to give this presentation. Are you still jet lagged?
I'm quite okay.
All right, you look good.
Thank you. So.
So our good friend Amir Aziz, great to hear from you, Amir. Pre-op, they have a Ilizarov halopelvic traction device to correct this deformity, and they do 3 millimeters per day, even for 6 weeks if needed. And again, my point to that is I love that you're having that. I'd love to have you on here and show us that in a couple of cases. I've seen some of your cases. They're very cool. Great to, again, hear your thoughts, Amir. And again, we don't have that technology. I'd love to learn more about it. But this guy was truly not moving. So with hardware in there, although it's loose, I'm not sure where it goes, but I'd love to hear you on here. So let's be in touch later. And hi, Dr. Sabit, and Happy New Year, and thank you for your greetings.
Okay.
So preoperative traction, you mentioned it. Did you do it at UCLA or in Boston or?
Yes, I worked with, during my deformity rotation, did some cases with Stu Hirschman. We did that quite a bit. We also did it at UCLA when we were doing the pediatric scoliosis rotation.
In kids or adults?
In kids.
Yeah.
Right. But in adults while I was at MGH.
All right. So fire away.
Yeah. So thank you for a nice introduction, Dr. Chapman. I'm presenting a case of a 76-year-old patient who has a history of a MIS L2 to 5 PSIF 8 years earlier for left lower extremity sciatica and low back pain with complicated post-operative course, including 3 follow-up surgeries, wound infection, CSF leak requiring repair. Now the patient is coming to our clinic and complaining about neck pain and increasingly disabling low back pain over the last year. She's worried about loss of hand and leg coordination with progressive difficulty walking and also an increasingly forward bend position. She also reports a recent bladder incontinence in the last month and she noticed a hard mass under the skin protruding from the upper end of her previous hardware. Regarding her past medical histories, she has severe rheumatoid arthritis since her 80s. She has a daily use of 6 milligram of prednisolone, and also osteoporosis with previous Prolia injections. Regarding her motor exam, we couldn't see any loss of muscle strength, but a hyperreflexia to the triceps and a decreased sensation to her right and left leg with no dermatomal overlap and no abnormalities in the lab. So these are the X-rays. What we can easily see is that we have an L2 fracture, so the pedicle screws of L2 absolutely fractured out of its original position. We have a persistent reversal of the lumbar lordosis, and we have the status post-fusion L2 to L5, what we see right here. So following to the X-rays, also because of the myelopathic situation, we performed a CT myelogram of the whole spine. So these are the images of the lumbar spine. And what we see right here, what we could already guess from the X-ray images, we have the severe rostral hardware failure with unstable non-union L2-3 and retropulsed cage L2-3. The L2 screws have cut out completely and are rostral to pedicle in the soft tissue. Yeah, let's go through the actuals as well.
So again, prior to this, the last surgery, she had an L3 to 5 MIS fusion done, and she had a pretty rapid adjacent segment collapse at L2-3, and then she had an open, again, this is not done here, procedure done with a non-union now of a peak cage, and she had a postoperative infection, CSF leak. She had a wide laminectomy done. And so she has an established non-union. Now the surgeon told the patient, we're not touching this ever again, because she had an infection. She was in the hospital for a long time, 3 months or even longer. Maybe, I forgot the number.
I think it
3
was
to
even-
6 months. It was a
even more than
very
3
long
months.
time.
Yeah.
And she remembers that very traumatically. Now her rods are coming through the skin. Literally they're subcuticular, I would even say. And she can't sit anymore. She can't lay on her back anymore. So something has to be done. And again, here we are. So thoughts. So how do we correct this now? We have a non-unit L2-3. We have a kyphosis. She never got fused into 5-1. Do you mind going through the sagittals one more time, Garrett?
Sure.
So she has an unfused 5-1 segment with a weird hyper lordotic spondy. She had cortical screws at L5. And again, she has a history of a CSF leak. There's no ongoing leakage on CT myelo, but this was apparently also a big deal at the time. And again, history of a bad wound infection, an immune-compromised patient.
Sure. Another great case, a great presentation. I think this is a bad problem, but I certainly think it's something that can be fixed. She, first of all, need to assess and repair the fusion at L2, L3. Secondly, it appears that she has some instability at the L5-S1 level, so that would need to be included in a construct. And she has proximal junctional failure at L2 and pretty focal sort of thoracolumbar kyphosis in that region. So I would sort of span that and correct that with sort of the construct to address this. And it sounds like she had some claudicatory or radicular symptoms.
Yes. I'm just coming to this. It's the next slide. So as I mentioned, we also did the CT of the whole spine. So this thoracic CT didn't show any abnormalities, but I just wanted to show the cervical CT myelogram. And what we see is right here. The quality is unfortunately not too good. We see diffuse cervical spondylosis, moderately severe stenosis, but with no cord signal changes, sorry, and no actual cord compression. So this is just to give you the whole overview of the cervical spine. So let me just summarize what we know so far. We have a 76-year-old patient. Her complaints are low back pain, right lower extremity pain with status post L2 to 5 fusion with complicated postoperative course, as well as neck pain with cervical myelopathy with worsening hand function, difficulty walking, and decreased sensation of right and left leg. From the images, we know that we have an unstable non-union at L2-3 junction with severe loosening of the rostral and of the posterior instrumentation with a stable fusion L3 to 5. and a multi-level spondylosis of her cervical spine with worse stenosis C4-5 and C5-6, and also the comorbidities, which are severe, thinking of the rheumatoid arthritis and the osteoporosis.
All right, and the cervical spine is typical hyperlordotic cervical disease in a patient who has a substantial thoracolumbar kyphosis. Thoughts, do you mind going forwards then, or maybe going backwards once? So comprehensive reinstrumentation, how high would you go? Compromised host?
Sure. In this patient, right, again, she's osteoporosis and has rheumatoid arthritis. She would need a very robustly biomechanically stable construct. And for that reason, I may consider going beyond T10, and I may consider going up to T4. But that will depend on what her lumbopelvic parameters look like. If she has a significant uncompensated sagittal imbalance, then I would consider going higher to T4.
So she's a retroflexed sacrum. So she's maximally compensated, and she has this bizarre, as I said earlier, hyperextension spondylolisthesis with severe foraminal stenosis. Rod, you're a master of XLIFs. Would you, if I called you about this, would you fish out that L23 cage for me?
Definitely would consider it, but I'd probably get a CT scan to see.
Yeah.
It looks like it's fused.
No, L23 is not fused. If you
Oh, it's not. Okay. Oh, yeah.
It's cavitated
Yeah.
quite clearly.
I mean, potentially, but I think you can get it out from the back too. So,
All right, Garrett, let's show us.
or just leave it.
All right. So what we did, considering the whole situation of the patient with the comorbidities, etc., we said that we first want to address the lumbar spine with a posterior complex hardware removal L2 to L5, with the PSIF from T7 to pelvic, with also adjacent segment vertebroplasty, and in the second session, then the cervical surgery with multi-level posterior decompression and fusion. So this is how the X-rays looked following surgery. So we have a great alignment. We have a great upper fusion up to the T7 level, including some hooks as well, right there. So far so good. We had initially a pleasant postoperative development with functional improvement and uncomplicated course until discharge. Unfortunately, about 3 weeks post-surgery, the patient presented to the emergency room in an acute septic situation with significant symptoms of severe hypertension, elevated white blood cells, elevated C-reactive protein, significant back pain, and already reduced general condition. So what we did is we performed an MRI. And although unfortunately the quality is not too good because of a lot of artifacts, but we see that within the operative bed there is a heterogeneous single fluid collection with rim enhancement, which is raising the concern for an infected fluid collection. Especially considering the whole situation of the patient. We see no contribution to the central canal compression or any obvious epidural involvement, other than the extending of the dural margin that we saw here at the following laminoplasty at L4-5. We also performed a CT. I want to show you right here. What we see is that the hardware construct appears intact. We also see right here paraspinal muscular changes, including non-specific areas of fluid and soft tissue emphysema. You can see right here in the muscles. And also the axial images. We obviously made the images, including also the whole construct, including the thoracic area, but unfortunately the quality wasn't too good, so I just concentrated on showing you the lumbar images right here.
All right, we'll have to come to a conclusion, so 3 more minutes.
So following emergency consent of the patient, we took her into the operating room, and we performed a total of 4 additional surgeries, including intensive washouts, drainage, debridement, and VAC therapy. We could identify a pseudomonas, a gram-negative pseudomonas, in the wound. We managed a final closure on the fourth surgery with the help of our plastic surgery specialist via debridement and back pain, and also including a left trapezius and latissimus dorsi myocutaneous flap. Right now the patient is still on antibiotic treatment. It's a pretty recent case, so this is what we know so far.
Can you show us the post-operative CT reconstruction that you had? So we did a fairly major surgery. We did this obviously knowing that the patient had a previous infection. She had a urinary tract infection as the most likely source. Can you go back a little bit more to the scout film immediately after surgery? And I did remove those 2 pairs of hooks also because they had kind of loosened. So this saga is probably not over yet, but would there have been a less invasive way to do this? Would there have been a way to avoid this in the first place?
No. Well, like in the first place, the way the patient presented, or?
Yeah, maybe, yeah. So going back to that, so she had something that I see a lot in my clinic. I see a lot of L3 to 5, nicely done MIS surgeries for reasons that I'm not always that sure about, but they're technically well done, and then the patients fall apart above and below. And then at some point in time, maybe there's one additional MIS surgery done at the level above, usually not below, and then they come for deformity correction. It's not as extreme as this one, but it's a common phenomenon for me now. I don't know, do you see it also?
Yeah, I mean, I'm not seeing it as much, and usually when I see those cases, I just send them to you.
Well, thank you. No, but so for me, this is obviously a dilemma because we had this is a wonderful lady, and we've had extensive discussions, and she was obviously from her past experience highly traumatized. She actually took this one in far greater stride, but still there was a mess afterwards. I mean, she's functional, she's neurologically intact, she has a much better alignment, nothing's poking through her skin now, but we played this slow. Rod saved her life by taking her to the OR in the middle of the night because she came in with gram-negative sepsis. Thank you, Rod. Any thoughts from your end, Rod? Should we have done something differently?
No, I mean, this is a beautiful reconstruction and shows you the power of the intradiscal osteotomy and to be able to get the coronal and sagittal correction. I think, her bone quality, what was, did she get a DEXA or?
So we measured the Hounsfield units were 89.
I mean, I think that's always challenging with these cases, but I mean, it's a beautiful result.
Yeah, so far so good. Now, this is again the problem of spine surgery and especially fusion surgery. It's an evolving process as life goes on. People age and things happen. And she was not looking forward to surgery. She had actually, her previous surgeon had told her just live with it. But when the rods started coming through the skin, literally, the time had come to do something. And again, we did not go into this without knowledge, but the soft tissues were significant. The point here was that with an AI evolving scenario, her risk profile would have been 100, 200, 300%. And the question is in the future, will we be allowed to do this? Will a ChatGPT directed medical administrator say, no, you're not doing this?
Well, I hope not, and that's why it's enabling technology. It's technology that should inform our decisions. I think at the end of the day, we should have the final say. So, I mean, you have this patient who has this impending wound breakdown and lifetime infection of the implants, and it needed to be done.
All right.
All right.
Thank you. Great. So I'll come up front. Thank you, Garrett, and glad to have you back. And I'm going to X you out of here. So it's fantastic to have Dr. Ken Nwosu here in person. And I hope we'll see your talk here. Where is it? This is it? Yeah. Oh, cool. Nice graphs. So Dr. Ken Nwosu is a wonderful colleague. As I said earlier, he is a graduate of the medical school and residency at UCLA, one of the premier programs in the country. Dr. Skuin is very partial to that also. He did his fellowship at MGH in the Brigham in the combined program there, and he works in NeoSpine, which is a very well-known group in the Pacific Northwest. He's just 30 miles south of us, right, and does complex spines, and he's one of those brilliant young surgeons who also looks at new technologies, and he's going to talk about how this impacted his practice and where he sees this going in the future. I see a Tesla already on autopilot. This is Dr. Skuin driving in from the Sammamish Plateau this morning.
Thank you so much for having me, and thank everyone who makes this possible. I'm a big fan and a big consumer, so it's an honor to be invited. So first and foremost, Happy New Year. I don't know about you all, but I'm pretty excited to get back to work after spending a little too much time with these people. This is my family, and we had a great time together. And we did some traveling to see other family, and I found out that my 4-year-old daughter can chug a beer better than I can. So that was a little embarrassing. That's not beer, that's apple juice. So don't write me up.
The Bavarian child.
I did get a lot of rest, but ultimately excited about the future. And speaking about something futuristic, here is an experience that I had. I don't know if there's any volume of a self-driving Waymo car. My wife actually took a different car, a Tesla, because she does not like the idea of being in this. This actually drove me through the parking lot and through the freeway back to my hotel, about 20 miles. So it was very interesting in
Where was
Arizona.
that?
Arizona.
In Arizona?
Yeah, yeah, very cool. Okay, so the topic of my talk is changing spine surgery with enabling technology.
Is everything okay?
This isn't working, I don't think.
Otherwise, can you hit manual?
Okay, I'll just do it that way. Okay. So these are my disclosures. So today I'm going to be talking about my journey with the Excelsius GPS robot. I'm going to be speaking about the benefits, drawbacks, and the future utility of this technology. So this all falls under the umbrella term of computer-assisted surgery, which is essentially the use of computer technology to plan and execute surgeries. This typically happens in 3 steps. First of all, you have the image acquisition and processing. This usually happens pre and or intra-op, where with a 3D or 2D image acquisition system. Once the image is acquired, the data or the pixels from the image are processed, and it is converted to an image that differentiates between the tissue density and identifies landmarks for overlay for the surgical plan. After image acquisition, the planning occurs via specialized software that essentially creates a virtual 3D rendering of the spine that allows the user to manipulate it. And then after the plan is complete, then the plan has to be executed via navigation, which is essentially the use of an optical infrared camera to track instruments relative to the spine. It's specifically useful for cases where you cannot see the tip of your instruments, like MIS surgery. And then the next sort of step is robotics. This is essentially a mechanical device that is controlled by the computer. There are 3 types of robotic platforms out there. There's the supervised robot. There's the telemetry robot, which is essentially the Da Vinci. And the current robots that we use in spine surgery are the shared control robots, which are the only robots that are FDA approved and available commercially. So let's go down memory lane a little bit. So this is when we first procured the robot. It was delivered. I don't know what weirdo went out to the loading dock to take this picture. And after a few dry runs and some training, we were ready to do our first case, spoke with a few colleagues, and we tried to, select the right patient, straightforward anatomy, traditional approach, and the surgery went well. This was a patient with pseudoarthritis, a middle-aged man with thoracic ankylosing spondylitis and a pseudoarthrotic level with associated severe stenosis at that level. So we went in and we did a laminectomy in the thoracic spine and did an instrumented fusion 3 levels above and 3 levels below. And took some pictures after surgery, and everyone was high-fiving and everything was going well until it didn't. 3 weeks later, we got a call from the emergency department. Patient was having progressively worsening pain, feverish chills, got a CT scan, which showed a deep fluid accumulation, and he had an infection. So we took him back to the operating room for a deep wound washout, and while we're while we're washing them out, I'm cursing myself and, asking myself, why am I using this new technology? And in my typical sort of dark place, I call some friends to try to help me feel better about myself. And this is Andy Minista. He's in Olympia Ortho, and he'd been doing these robotic cases before I had. And this is also a good friend of mine, Amandeep Bala. And essentially what they said was just, have some faith and keep at it. Fast forward to the present, approximately 200 robotic assisted cases later, and over 1,000 pedicle screws with some logic, a leap of faith, and most importantly, the right team. Robotics for spine surgery is here to stay. So question is, why use robotics? Well, some of the rationale that I want to emphasize are the fact that it improves efficacy and efficiency. It doesn't just allow for more accurate screw placement, it allows for more optimal screw placement, and it also improves the MIS experience. It reduces intraoperative radiation. It has a relatively shallow learning curve and also reduces stress and cognitive load associated with surgery significantly. So here's a systematic review and a network meta-analysis by Paul Arnold et al., which assessed essentially the accuracy, the optimal placement, screw mount position, operative time, blood loss of robotics versus other sort of navigation platforms. And you can see here that robotic sort of guided surgery was superior in screw accuracy placement, in optimal placement, and in reduction of overall complication. And here's a case in point, typical standard case of mine. This is a middle-aged man who had significant low back pain and left-sided lumbar radiculopathy. He has some degenerative scoliosis, and he has a history of significant retroperitoneal surgery and scarring. So we elected to move away from retroperitoneal surgery. But you can see here that he had a paracentral disc herniation at L5S1 and had pretty significant left-sided foraminal stenosis at L3, L4, and L4, L5. So we did all the conservative treatments for him, and he didn't get any improvement. So we elected to proceed with surgery. So this is sort of the planning of this case, right? This is planning of the S2AI screw in an optimal sort of biomechanical position that maximizes fixation strength. This is another image of the surgical planning, which allows me a few things. It allows me to anticipate the issues that I may have to run into the case. Personally, after doing a case like this, the last thing I want to do is spend 15, 20 minutes contouring rods. So aligning the tulips is very important to me, especially with the S2AI screws, because sometimes they can be in funky locations to where it is difficult to place the rod seamlessly into all the tulips for a long construct. So this is the post-op image. And also the robot also allows me to adequately place the T-lift cages as well. Here's an example of a pretty small pedicle and the ability for a robot to plan a pedicle screw. This is a 4.5 by 40 millimeter screw, and you can see that it's cortical on a medial and a lateral pedicle wall, and we were able to execute this to the T. So robotics is actually pretty exciting because robotics is being used now in cervical spine surgery, and as indicated by Lieberman et al., who did a retrospective study on 12 consecutive patients, and he placed 88 screws. So what he was trying to do was to assess how reproducible the plan was to reality. So what they did was they got a preoperative CT, they planned the screw on the preoperative CT, and then after the surgery, they got a CT, and then they merged the CTs together to assess the deviation of the screw that was placed from the screw that was planned. So they placed 88 screws, and they noticed a 100% success rate and a 15% breach, all inconsequential, all medial. On average, they noticed about a 1 millimeter deviation in the axial plane and in the sagittal plane, which without any complications, essentially deeming that a particular screw placement with robotic surgery is feasible. In my opinion, this is where robotic spine surgery shines for MIS execution and the experience. And this is sort of relayed by this prospective multi-center study by Dr. Wong, which compared robotic guided and fluoroscopic guided techniques for MIS surgery. Surgical time was similar. However, there was 80% less fluoro time. Complication hazard ratio was about 5 times higher in fluoro guided. And then the revision hazard ratio was about 11 times higher in fluoro guided. So here's a case in point for me in my practice, how I utilize robotics for MIS surgery. This is a patient of mine, a middle-aged man who has previous history of L5S1 microdiscectomy on the right side, had 2 recurrences, and presented to see me with a third recurrence. So we elected to proceed with a TLIF of L5S1. And this is sort of my planning of the case. And what's nice with the robot is you're able to sort of reproducibly plan where you want the screws to be. You can also plan where you want the cage to be so that it's in the most biomechanical position. What I do with these TLIFs, because it's MIS, I oftentimes plan a facet fusion on the contralateral side, so I'm able to plan that with the robot and do that through the end effector of the robot in a very seamless fashion to hopefully increase the fusion rate associated with these cases. All right, robotic is also valuable for single position lateral. As we all know, doing a lateral and flipping the patient is associated with significantly increased OR time and risk of contamination. And there's been some studies that have shown that single position versus lateral then prone position is associated with reduced OR time. There had been some notions that it is difficult to obtain lordosis when you're doing a single position lateral. However, the study indicated that they were adequately able to obtain adequate lordosis with a single position. What the robot is able to do is it's also able to help navigate the cage placement, and it also provides a good ergonomic environment to place the pedicle screws when the patient's in the lateral position. The idea of single position sort of lateral surgery is evolving over time, and people are now starting to do the prone lateral. However, I'm starting to hear around the country that the risk of bowel injuries are a little bit on the high side, and I'd like to get you guys' thoughts on that now or at the end of the talk. It's not all peachy with robotic spine surgery. There is a significant learning curve in this study. This single sort of surgeon experience surgery study goes into that. This is a study at HSS where a single surgeon performed a retrospective study looking at sort of his robotic journey. And 364 pedicle screws were planned, and 311 screws were placed. And they found out that they had a 90% high grade optimal screw positioning. And the screws that had issues were mostly due to 2 issues. And number 1 was skiving, and number 2 was a soft tissue pressure on a drill guide. So if you do decide to embark on robotic spine surgery, just be mindful of these potential issues that can cause complications. So why is the Excelsius GPS superior in my opinion? I think it is because it's more portable. When I do these cases every once in a while, when I'm lucky, I'm able to stagger the cases and get a staggered room. It's a very portable robot. So, we place the screws. Once we place the screws, if I'm not using the navigation, it is able to be moved to another room without interrupting my flow. So that's pretty nice. I would say that the registration is also superior. I've used the other robot on the market at our surgery center, and the registration for the other sort of leading robot on the market is pretty laborious. This just requires an AP and a lateral. And my workflow is a preoperative CT to intraoperative fluoro. So it's quick and efficient. And then also for me, this is the most important thing, is the additional sort of contingency plan as it relates to losing your landmarks, and that's the surveillance marker. So you have a couple of, you have the DRB right here, or the dynamic robotic probes over here, and then you have the surveillance marker. So the optical infrared camera typically tracks this, and if there's any motion in this, then the robot is able to sense that there's a shift in the anatomical position of the patient. And most systems only utilize one of these. However, the Globus utilizes a second surveillance marker, which the infrared camera also tracks, and it tracks not just movement of the DRB, but it tracks movement of the DRB relative to the surveillance marker. And if there's a relative movement of greater than 1 millimeter, it notifies you. So what I found is that when you are doing cases more cranial in the spine, farther away from where the DRB is, this can be very helpful. So intraoperative radiation reduction is extremely important, obviously, and it hits home for me. My mentor, when I was in Boston, we would do a bunch of cases, and he would wear the lead skirt and the thoracic shield, and he wouldn't wear a top. And he would say something along the lines of, "Oh, as men, we don't have breast tissue, so there's no risk for cancer." He ended up having mediastinal lymphoma. And he's a leader in the field. Luckily, he's still with us now, but this concept specifically hits home for me. And it's a bit of a nebulous concept. We understand it. We don't see it when it's happening. So it's sometimes difficult to keep in the forefront of your mind. And the literature on robotic surgery and reduction on fluoroscopy is actually a little bit mixed. There's this meta-analysis that essentially didn't look into it because there was a significant amount of heterogeneity in reporting. However, this study out of Japan showed a significant reduction in fluoro time. And then another study showed a significant increase in fluoro time with robotic surgery compared to freehand technique for open surgery, which makes sense. Ultimately, I think as it relates to fluoro time reduction, the holy grail for robotic surgery is with MIS surgery, where this study showed over 80% reduction in fluoro time for the screw placement and over 50% reduction in fluoro time for the entire surgery. So learning curve is important. It's relatively shallow. However, it's important for us to move slowly through this process and recognize that there's a lot that we don't know. However, there's some studies that have looked into this showing that that there's no difference between attending and first participating fellow. And they also show that this sort of knowledge is very much transferable. However, again, we don't know what we don't know. And over time, if you keep your fingers on a pulse, you start to learn things from your colleagues. And something that I've learned and I've changed in my practice over time is hearing about some high profile complications associated with robotic use and starting to ask myself the question, like, what is the value in using a robot for an open short segment fusion surgery when I can do that pretty efficiently with freehand technique? So that's a question that I ask myself now. So this is a case in point on the learning curve of robotic. This is a case that I did while I was on call. This is a 75-year-old lady who had pretty significant spinal canal stenosis and significant degenerative scoliosis as well. And they had just procured a robot at Tacoma General Hospital in Tacoma. And I used it for the first time, and we were able to safely and effectively accomplish the case. This is a picture of my PA teaching the staff how to use the robot. So on the fly, we're teaching the staff how to use the robot and doing the case at the same time. So again, the learning curve, this just emphasizes the shallowness of that learning curve. All right, so some adjustments that I've made over time are a few fold. Number one is the DRB and the surveillance marker issues. If the DRB or the surveillance marker moves during these cases, it throws everything off anatomically. So I sort of protect movement or bumping into the DRB pretty significantly. But other issues can come up, like the 2 incisions that are associated with using 2 DRBs in surveillance marker. And sometimes you can inadvertently go into the SI joint, and oftentimes patients wake up from surgery and they're like, oh yeah, my back feels good, but now I'm having SI problems. I was doing one of these surgeries one time, and I hit the superior gluteal artery, and there was a significant amount of bleeding that was difficult to control. I had to send the patient to IR. So there is risk associated with placing an additional marker. I think it's very important to minimize soft tissue tension when you're doing these cases. Usually when I do these cases, before I put the burr on the bone, I start off the bone just to mitigate the risk of skiving. When I'm doing S2AI screws, I try to use a 60 millimeter drill bit that can drill through the cortex of the SI joint before placing the screws to avoid distraction of the joint. And for a single level L4 to S1, there's the question, is there any value in using a robot to perform an open sort of L4, L5 or L5 S1 fusion? When I do use the robot though, because of the lateral to medial trajectory of these pedicles, I will oftentimes consider placing the screws through stab incisions in the fascia to avoid the soft tissues from getting in the way. So lastly, there's the concept of reduced fatigue or cognitive stress associated with robotic use. And essentially this is the holy grail of enabling technologies, but it's something that we talk about often, but I think we have a hard time putting a finger on it because it's a hard concept to describe. However, it is pretty well described in the psychological literature where several studies have shown that all variants of effort draw at least partly on a shared pool of mental energy. So the implications are enormous. It sort of can enable you to be more safe in successive cases. It can enhance mental and physical health in this very mentally and physical burdensome field that we all partake in, and it can also significantly reduce burnout. So adjustments, again, that I'm going backwards. So again, these are the studies showing quantifying better that sort of reduced fatigue associated with robotic use. And this is a case that I would usually send to Dr. Chapman, but in a small community, sometimes these patients insist that it be done by me. So I sort of took it on. So this is a gentleman who had a previous L4 to S1 fusion, and he was fused relatively flat. He had pretty significant breakdown above the construct, and needed this to be addressed. So I took him for a 2-stage surgery. We did an ALIF at L2, L3, and L3, L4 level, and we were able to plan our screws, and we were able to execute our plan. And this is a case that I typically lose some sleep about a few days before surgery, on the day of surgery. This is a case where I would only book this one case on a day, but on this day I was able to do 2 other small percutaneous cases. I did 2 other ALIFs, and I was able to do percutaneous 1-level fusions on 2 other patients, and this case. And at the end of the day, I was ready to do more cases. So what are the drawbacks? Drawbacks are setup time. It is important to have a dedicated OR team to streamline workflow, which isn't always possible. And there's also a variation in quality of support for the platform. The one thing to recognize with these technologies is that they will fail. They will fail at some point. So I think it's important to recognize that will happen, and it's important to be prepared for when that happens. A hardware piece may be broken, there may be a wire missing. I think we do a disservice to our patients if these technologies fail, and then we have to cancel the case, which I've seen in certain instances. So they will fail. So I think understanding and being able to perform sort of good old-fashioned pedicle screw implantation is invaluable. So future considerations are the utility of robotics for cervical spine instrumentation, cervical pedicle screws, MRI to fluoro registration, which will minimize radiation exposure, not just to the surgeon and the staff, but also to the patient. Robotic guided decompression, which some robotic companies are already working on. And it'll be, I'm looking forward to the evolution from optical image tracking to electromagnetic image tracking, where sort of the line of sight isn't an issue and it can minimize lag and processing time. And then also augmented reality surgical navigation is already here. There's the Augmetics X-Vision FDA that's already approved and is being utilized and has been shown to actually be associated with reduced radiation rate compared to robotics. So in conclusion, computer-assisted surgery is here to stay. Traditional principles are invaluable, and robotics and spine surgery improves efficacy and efficiency. It reduces occupational hazard, and I'm excited about the future because I think it's bright. All right, thank you.
Thank you, Ken. That was a very honest and cool outlook. And if you don't mind going back to one of those previous slides of the trajectory. So yeah, this is very cool. So the preoperative planning clearly becomes a far greater deal, the mental interaction with the patient. You very honestly identified that there is a higher radiation burden for the patients because they have to have 1 or 2 millimeter cuts beforehand to get these kind of high quality images. How does that then in the net for the patient work its way out? Do the patients have a lower radiation burden, or with that high definition CT scan, a higher radiation burden?
Sure. So I think that the patients have a higher radiation burden, and the concept of reduction in radiation burden and fluoro time, that is primarily for the surgeon and the operating room staff. However, I think with future sort of iterations of robotic technology and being able to utilize MRIs and fusing those preoperative MRIs to intraoperative fluoroscopies, I think that will significantly reduce the burden to the patient. But currently, we are not there yet.
And then if you don't mind going back to a slide of that lateral position. So is it your current preference that you had a lateral slide where you had a single stage lateral surgery? So one problem that I've heard about these lateral surgeries is despite having high-tech, cool anti-skive technologies, for instance, that one, there is a skewing effect where literally you can tell on the x-rays whether the patient was having same day, same setting lateral surgery, because the skews kind of go in catawampas. They kind of are in a parallelogram effect. Have you seen that? Are you avoiding that? Is that something that we can account for or correct?
Sure. Can you elaborate on that?
So when a patient has pedicle screws put in a lateral position, the down screws, so meaning in this patient, the right-sided screws will always skew downwards, despite having a high precision computer assist device. You can literally tell this was a same setting lateral surgery. Have you not seen that?
I have. I think it's something that you have to be mindful about, and I think it can be avoided. And some of the things that we do to avoid it is we sort of, in these cases, typically we bring the anterior aspect of the patient to the edge of the bed. But when I'm doing single position lateral, I actually bring the posterior aspect of the patient to the edge of the bed. I plan the downside screws to be more medial than normal. The Excelsius GPS actually has a force meter that is able to identify 200 Newton forces of Newton meters of lateral force. So it innately tries to avoid that. So yes, it is something that's not uncommon, especially with sort of fluoroscopic screw placement, but it is something that I think can be mitigated.
Do you still then do lateral, same setting surgery? Is that your preference?
Yes.
Okay.
For a single level lateral, that's my preference. Yes.
Rod, so Dr. Nwosu talked about prone position surgeries, and you're very adept at far lateral XLIF type surgeries. What are your thoughts on prone position surgery and where are the dangers? Dr. Nwosu was talking about that there's some possible greater risk to bowel injuries and things like that.
I mean, I think that for me, when you're doing lateral, I mean, it's really the lumbar plexus, right? So I think the peritoneal abdominal organs and things like that are always going to be an issue. But I think for me, I think using technology like navigation is helpful, but I think it really comes down to, especially if you're doing L4-5 and L3-4, so I think neuromonitoring is the key for me. So, I mean, you can do it sideways, prone, upside down, doesn't matter. You still have to be able to map the plexus and make sure you don't get a lumbar plexus injury.
Okay, thank you.
So,
Do you do your own monitoring?
I do not use neuromonitoring currently. I do an enter to SOAS approach. So I.
oh, you do? Okay.
Right. So
Prone?
No, not prone. I
Okay.
don't do prone. I have some friends that have done.
Supine?
Lateral, I'll do an enter to
Oh, okay.
SOAS approach for the laterals, and sometimes 5
With navigation?
with navigation.
Okay.
Correct. But without, I think without neuromonitoring.
Okay.
Right.
So then, final question. Thank you for being so indulgent also with all my questions. Always have questions.
I love them.
You talked about maybe short segment fixations being more something for open surgeries versus a percutaneous or MIS type surgery. Can you elaborate on that, or not using robotics for that? I'm not sure that I understood you fully. So short segment surgery, what's your preference?
Sure. So my preference in short segment open surgery, when I have to do a laminectomy and an instrumented fusion in an elderly patient where I don't want to put an interbody cage in there because they have osteoporosis, would be to do it open without a robot. Again, there's been some high profile cases on the East Coast with catastrophic robotic failures. So now the pendulum is sort of swinging and people are now starting to ask the question, like, what is who is the right patient to use a robot on and who is not the right patient to use a robot on? And for me, the robot really shines with MIS surgery where you cannot see the tip of your instrument. But when you're doing a short segment sort of fusion surgery, the incremental value as it relates to efficacy, efficiency, and fluoral exposure, that incremental benefit reduces significantly to where it may not be worth it.
Interesting. I thought that's a very thought-provoking statement. And indeed, again, when I see some of those patients who get anterior and anterolateral surgeries that have severe atherosclerosis, and then there are significant medical sequelae from that, I question the beauty of the small incision is very tempting. The reality of dealing with an aging patient with atherosclerosis or so is pretty substantial. And yes, Cliff. Oh, yeah.
Yeah, thanks for the great talk. My experience with the robot has just been in the lab so far in my training. Is the robot help you with getting bony fusion as far as posterior lateral or your facet fusion outside of just placing hardware? Is it, if you're using an MIS approach, can it assist you in actually obtaining that osseous fusion?
Right. So I've found that it can, and again, the way I typically do an MIS TLIF, I personally am not a big fan of an MIS TLIF. I'm just not able to technically do enough of the disc work that I think is needed in MIS TLIF. I would much rather do a lateral or an ALIF, but in some situations it's needed. So in those situations, I try not to rely fully on the cage. I try to also get a contralateral facet fusion. I do posterior lateral fusions, but theoretically, I recognize that the facet opposes one another more closely. So it may be valuable to try to get a fusion there without doing significant soft tissue stripping in a patient. So what the robot does is and I actually have a picture of that here, I'm able to plant a screw that's going into the facet joint, and if you can see this picture over here. I'm able to plant a screw going into the facet joint, and the robotic end effector goes into that path, and I'm able to put a dilator in through the robotic end effector. I'm able to decorticate that area, and then I'm able to put some bone graft in that area. And sometimes I'll leave the tube in there, take the robotic end effector out, dilate the tube, and actually visually do the decortication and placement of screws. And I think this is something that I'm able to do in about 2 minutes. And I think if I had to do it without the robot, it would probably take more like 5 to 10 minutes.
Okay. That's helpful.
We must close. Thank you. Thanks for leading off the year with a great lecture. Thanks for coming up.
Oh, thanks so much for having me.